Delivery with forceps, relearning a dying art. A brief history. Forceps were invented in the 16th century by the Chamberlain family of surgeons and obstetricians. This family used forceps to perform safer and faster deliveries, bringing them wealth and fame amongst the medical community. The Chamberlains kept forceps a family secret for over 150 years, but by the 1700s, forceps had leaked their way into the hands of many obstetricians. Improvements were made to their original design, and by 1751, Dr. William Smellie wrote a treatise on the theory and practice of midwifery, after which use of forceps would become a common obstetrical practice for over 2 centuries. But recent trends have turned away from the forceps. With rising concerns about fetal and maternal injury with operative vaginal deliveries and safer C-section techniques, many women and physicians have been opting for the latter. Since 1996, there's been a dramatic rise in C-sections, and in fact by 2004, 3 out of 10 deliveries in the U.S. were via C-section. Meanwhile, operative vaginal deliveries are on the decline, with vacuum-assisted vaginal deliveries accounting for 0.8% and forceps-assisted vaginal deliveries at 0.4% of all deliveries. And furthermore, while C-sections are safer than they were in the past, there's still major abdominal surgeries with various immediate maternal and neonatal risks, as well as long-term morbidities. As ACOG reported in the Consensus Report of 2014, Safe Prevention of Primary Cesarean Section, this increased rate of C-sections has not shown clear evidence of a decrease in maternal or neonatal morbidity or mortality. Operative vaginal deliveries can prevent the need for cesarean section and can be a faster solution in key situations like maternal exhaustion, non-reassuring fetal heart tracings. So, why forceps? Why should we care about training our residents to use forceps when most residents are well trained in using vacuums? That's because forceps have a lower rate of neonatal complications, as with cephalahematomas and shoulder dystocias. Moreover, forceps have a higher success rate than vacuums, i.e., lower C-section rates. There are various types of forceps. Knowing which ones to use can be daunting. For example, the Piper forceps used for breech extractions don't have a pelvic curve, while Simpson's forceps used for outlet extractions do. Parts of the forceps include the toe, the heel, the shanks, which can be parallel or overlapping, the lock, the finger guide, and the handle. All forceps have a cephalic curve to grip the neonatal head, while only some have a pelvic curve. Conditions for forceps delivery include fully dilated cervix, an engaged head, knowledge of the presentation, ruptured membranes, no cephalopelvic disproportion, and an empty bladder. Hold the left forceps blade lightly in the left hand. Using the right hand, protect the vaginal wall while using the thumb to gently place the forceps blade into position. Repeat on the right side. Holding the right forceps blade lightly in the right hand, use the left hand to protect the vaginal wall while using the thumb to gently place the forceps into position. Lock the handle and feel for correct placement. Safety checkpoint. Confirm correct placement by noting that 1. The sagittal suture is parallel to and bisected by the plane of the shanks. 2. The horizontal plane of the shanks has 2 finger breadths anterior to the posterior fontanelle. And 3. Only 1 finger can be introduced between the heel of the fenestration and the head. Hold the blade horizontally with the dominant hand, pull straight with the dominant hand, and push downward with the opposite hand. Once the occiput comes under the pubic symphysis, stop pulling horizontally and start pulling upwards. Then, slowly disarticulate the forceps and pull them out gently to prepare for delivery. Congratulations, you have successfully used forceps. Residents in all OB/GYN training programs should learn how to use forceps through videos, simulations, and clinical practice. Studies show that clinical training can reduce the rate of complications in forceps delivery by 22%. So where do we go from here? Forceps can be an excellent tool for any obstetrician during a difficult delivery. They can be safely used in many situations if the physician is appropriately trained. We should make the commitment to continue this old art form. From the Chamberlain family of the 16th century to the OBGYN physicians practicing today, there is a vital role for forceps in our obstetrical repertoire. Let's remember the past while looking forward to the future, and may the forceps revival continue on.